Hi, good morning to everyone. I have to make three comments. The first one, to say a big thanks to the organizing committee of the A&R. It's a great pleasure to be here. The second one is that I'm very impressed with the attendance of the educational session. It is really good to see everyone here. And the third one is that I am exhausted with the intensity of the talks this morning. We haven't had a minute to breathe. No one has asked a question. So I think I would like to use about 30 seconds of this watch that is counting for you to take a deep breath, relax. I'm not very good at yoga or these kind of things, but take a deep breath. We are all trying to give very comprehensive talks and cover a lot of novelties. The good thing is that there are a lot of novelties. There's a lot to tell, and every time that I give one of these review talks, I go back to what we were saying years ago, and I think there's massive improvements in all of the topics that you've heard today, but also in the treatment for relapsed neuroblastoma. So that's very good news. But please take a deep breath, and then let's get started. Before we start. This is a slide that we've been working on for some time. Is how do we treat relapse? And a few years ago, we just gave some chemotherapy, and the patients progressed and died rapidly. And with more treatment options, there are more things to do for relapse patients. So I think we all agree that when we see a relapse high-risk neuroblastoma, we should try to mimic some kind of strategy as we use in frontline. We should give some form of induction to the patients and then try to consolidate that response and give some sort of maintenance. Obviously not with the same treatment modalities, but try to follow the same approach. The standard was to give chemotherapy at relapse, but actually probably that will not hold for very long. We need to give chemotherapy with immunotherapy, chemotherapy with targeted agents, chemotherapy combinations together with the molecular profiling for all patients with relapsed neuroblastoma. I think that's a good shift in the paradigm of how we're treating relapsed neuroblastomas. The patients might, of course, experience further progression, and they could participate in phase 1 trials. These trials could be guided by their molecular profile or not. Some patients still progress very rapidly and need to be offered palliative care relatively early. But some other patients go from one phase 1 trial to another phase 1 trial, and they stay well for some time. Patients that, on the other hand, have a response or stabilize their disease, well, for some of our patients that we remember, we just continued giving chemotherapy. So let's give them temozolomide for 1 year, and then what to do? Then one more year, and you end up without having when to stop. So we do need options of how to treat patients that respond or stabilize their disease. And we've got a lot of options. We've got a lot of options because we don't know which one is the best option yet. But it is good that we can continue chemotherapy. We can put the patients on phase 1 trials or give them targeted therapies guided by their molecular profiling. There's a role for MABG therapy, as Steve mentioned. And there's a role for different modalities of immunotherapy that we'll try to cover. Because to make it even more complex, this talk was not only to talk about relapsed neuroblastoma, but to talk about how to treat refractory neuroblastoma. So far, we've been lumping the two conditions together. All phase 1 and phase 2 trials include relapsed and refractory patients together, and probably that is okay to work because we still do not know how different the strategies have to be, but they are not the same. And you must remember that refractory patients, if they achieve some sort of response or control of their disease, they should go back to the frontline strategy and receive all the treatments that they didn't get at the beginning. So they need to get high-dose chemotherapy, they need to get immunotherapy, as they would have done if they weren't refractory at the beginning. I wanted to cover, or to give you a snapshot of these 4 topics. One is a question that I still find very intriguing. Are there any relapses in neuroblastoma that are curable with all these new advances and with all these new trials? Are some patients with refractory neuroblastoma curable? And then we'll go through chemoimmunotherapy, which is a big advance and great promise at the moment for relapsed neuroblastoma, touch on target agents and molecular profiling, and a bit of consolidation and maintenance therapies. This is the largest study done with the INRG that Wendy London did. Here we saw that patients with stage 4 MECAN-amplified disease, older patients and earlier relapses were the ones doing worse. And survival at 5 years was 8% for any relapsed stage 4 patient older than 18 months, 4% if they had MECAN amplification. So that's really, really low, and that's the most solid data that we've got in a large number of patients with long follow-up. Trying to get a bit more, a bit earlier, a bit more contemporaneous data, I looked at this slide from the ANBL 0532, and there is a gap between OS and EFS, and that gap used to be minimal, so the patients had first progression and then died shortly after, whereas now there's a bigger gap between event-free survival and overall survival, and there's a similar gap, although there are 2 different graphs. But in the COPEN trial, there's again a gap between EFS and OS. So the patients, when they relapse, they have survival, but it does look like that at the end, after a few years, the 2 curves again come together, and that would say that at least in the bigger picture, these patients are not cured in the long term. They have longer survival when they relapse, but not in the long term. There is a study done in the UK analyzing patients with relapsed neuroblastoma in 4 UK centers, and one of their findings is that when you compare before or after 2000, yes, there is a little improvement, and survival was less than 5% before, and it is around 10% now. So it's dreadful, but there is an improvement. I think the good thing is that it does show that some patients, the curves are pretty horizontal, and there is a little improvement in some patients, and we do not know what will happen to these patients in the long term. But then on the other hand, we come to the results of early clinical trials. And here you can see one, patients in second complete remission or further complete remissions from Memorial Sloan Kettering, very nice curve. Another one from the chemoimmunotherapy COG ANBL 1221 trial, another one from the alisertib trial, and these trials have survivals much better than the 10% or 5% or lower that we've seen. They all have in common that they are very small trials. They don't have very long follow-up because we're very anxious to report early phase clinical trials, and we don't have these follow-up yet, and the trials are relatively contemporaneous, so we still don't know what will happen to this or to this or to this. Obviously, there's some selection in these trials. Patients in trials in general are in better shape, and if you are in CR, you do even better than the ones that are not in CR. But if this data is encouraging, how can we translate that into a bigger picture so that in the next trials that we are doing now, the gap between EFS and OS is bigger, and we manage to cure, even if it's possible, a small proportion of patients. So that's for all of us to work on it. How do refractory patients with refractory neuroblastoma do? If you look at in the frontline studies, the studies that have been done in collaboration with the COG and COPEN, having a poor response, a poor metastatic response is a bad prognostic factor, and these patients are refractory. But rarely the refractory patient population is reported separately in the phase 2 trials. And we've done similar attempts to put together the data from patients with refractory versus relapsed disease in COG and in COPN. And there is a bit of a difference with patients with refractory disease. This is here, the blue ones in EFS and in overall survival. They do a bit better in the early phase trials. And these are COPN phase 2 trials, but they don't do so well. And the curves have a 50% survival because the follow-up of the trials stopped and is still short. So I think we can assume that refractory patients have a bit better outcome than relapsed patients, but it's still not higher than 20%. So I think we still don't know if there is a proportion of patients with relapsed neuroblastoma that can be cured. I think we more and more have patients that have participated in different early clinical trials and different strategies who are surviving longer, and they're getting to 3 years or 4 years or 5 years, but we still cannot know upfront when they relapse whether a patient can be curable or not. The next aspect to talk is chemoimmunotherapy. And I think most of you will be familiar with the data. The most remarkable one is a study done by the Children's Oncology Group, where they did a randomized study where half of the patients received chemotherapy with irinotecan and temozolomide, which is the standard, together with temsirolimus and an mTOR inhibitor, and the other half got chemotherapy, the same chemotherapy, with dinutuximab, the anti-GD2 monoclonal antibody. And I think that's it's very nice when you look at it now, but I think at the beginning all the investigators must have faced a number of criticisms because it was just impossible. It was one of these paradigms. You do never use immunotherapy together with chemotherapy, and I've heard it millions of times before seeing this, and I think it just shows that you sometimes need to challenge the paradigms that are not based on data. I don't think we really know the reason why it does work, but it does work beautifully. So they went on this trial. Their initial report showed that their responses in the temsirolimus arm were very low, or even lower than the ones that you got with chemotherapy alone, and the response in the chemoimmunotherapy arm were higher than 50%, which is a remarkable response for a relapse trial, for a relapsed and refractory trial. And even in the publication, that translated into a benefit in progression-free survival, which it's even more remarkable because that's an outcome that benefits the patients. The patients might not care that much of how big the tumor is or how big their MIBG score is, but actually they do care if progression-free survival is longer, and there's a clear benefit here. And you should not miss a presentation later in the meeting about the continuation of the trial. So the temsirolimus arm was closed, and there was an extension with 50 more patients that will be reported. There's another regimen developed by the group at St. Jude using a different antibody, using 3 different cycles of chemotherapy together with the antibody. And this had good high response rates in patients with relapsed and refractory neuroblastoma. And they have also piloted it in frontline therapy with the COG-type induction regimen, and good responses that will also be updated in this ANR. So for chemoimmunotherapy, there are very positive signals of activity. It has higher response rates and higher PFS than what we know up till now for relapsed and refractory neuroblastoma. Interestingly, it can be combined. It seems that it works with different monoclonal antibodies and with different backbone chemotherapy regimens. So there's not a specific synergy with one of the regimens, but it's just that it is a good idea to give the 2 modalities together. There is toxicity. we know that monoclonal antibodies, the anti-GD2 antibodies, have toxicities, but it is manageable. And when you consider the benefits and the risks of the approach, I do believe that the benefit-risk ratio is positive, but it's still a therapy that is different from giving just temozolomide or just chemotherapy in daycare. There is a very clear potential to bring to frontline, which is something that we're looking forward to do in every relapse trial. And there is a lot of work in different regions of the world to bring these drugs to frontline. And that's a very interesting question. Has it become the new standard of care with the data that we know until before today, from this week onwards? Will it become the new standard of care? I believe that in North America, it is routinely given, chemotherapy with dinutuximab for patients with relapsed and refractory neuroblastoma. I think in Europe or in other regions of the world, it is not that easy to have access to that because of the different health systems and because of other differences. And I think that's part of the debate of how much evidence do we need to change what we call the standard. On the other hand, there is a desperate need for new therapies because these patients do have a desperate need for new therapies. And I think that the reflection I would make is that we need to make sure that the trials that we do reach the patient, reach changes, so that it's not only what we do in the trial, but afterwards all my colleagues will be able to prescribe this drug and make that change. And that change has happened in North America, but we haven't managed to change that in other regions of the world. So that's part of the whole package of doing clinical trials, include making sure that you will be able to convince the ones that are going to pay for it afterwards. And what are we going to do next? If this is the new standard of care, we need to rethink all our plans and all the permutations of the initial algorithm that I showed. So we're thinking hard, I think, between all of us, and will be very interesting to see the data that will come out in these 1 or 2 years and see how we take this forward. And if we do this in frontline, are we doing to give antibody twice in frontline and then again at relapse, and how to incorporate the new drugs? Another point for another aspect is not the chemoimmunotherapy, but how to incorporate other targeted agents, molecular profiling, and the efforts in drug development. You're familiar with this picture. There's tons of targeted agents being developed for adult cancers, and we do need a way of organizing that work and seeing which ones we need to take forward in neuroblastoma, which ones are more attractive for neuroblastoma. I think it's worth mentioning an initiative that Andy Pearson has led that started in Europe, that it's called the NDDS. And this is putting together clinicians, scientists, and regulators. We had a first meeting in 2012 where we evaluated between all of us 20 targets. 6 of them were top priority, meaning that these should be fast-tracked for clinical trials, and we should persuade regulators and pharmaceutical companies to do trials in these with these targets. So, for example, for ALK, clearly there has been a lot of advances. We've studied different compounds in early trials, gone into combination. Crizotinib is even being tested in frontline. There's the 3rd generation ALK inhibitor already starting, so there's a lot of activity in the ALK field. Aurora kinase inhibitors, there have been 2 compounds, one alisertib being fully developed in phase 1, phase 2, combination with chemotherapy. So the data that we needed for these drugs has been generated, but for others, 6 years later, for MDM2, it just started this year or the year before. For BRCA5, for CHEK1, there's no pediatric trial still. For the mTORC1/2, it just started again last year. So it's not that easy to convince the pharmaceutical companies to bring these drugs into pediatric trials. And we had a second meeting last year in a nice place in Cambridge, where we also invited members from pharmaceutical companies, from parents associations, and experts from North America, and as well as from Europe. So there's a nice enhanced global collaboration. We had a focus on epigenetic targets and MICAN, but still more than 40 targets were reviewed, with emphasis in combinations, with emphasis in combining the drugs with immunotherapy. But still, we were able to classify the targets. There are some targets that are high priority, have drugs, and there are pediatric trials open or just about to open. There are some targets which are high priority, have drugs, but there's no hint of a pediatric trial. And we should put our efforts to facilitate these trials where possible. And then there's even some other trials where, some other targets, sorry, where there's no drugs. And that's the nice aspect is that this is a continuously evolving thing. And we thought in September that there were no drugs to target these targets. And actually there's some nice presentations in this ANR to show strategies to target some of these targets. Gudrun already mentioned molecular profiling efforts. I think I'll only highlight this aspect. This step here is the molecular tumor board, which is something that we all need to incorporate in our routine practice. All the practicing oncologists need to try to attend these meetings, try to participate in these meetings, and keep in mind that it is very important to merge the clinical, biological, genomic information with the clinical knowledge together with the actual options that the patient has got. So there's, I encourage everyone to try to participate to these meetings and make the most out of them, because they're truly helpful for the patients. So that's the routine. The routine of all the profiling programs is similar, and there are different programs in both sides of the world. What are we learning from them? I think Gudrun has touched on many of these aspects. We are still early days, so there's not big data from large sets of patients, but we need to continue getting this data and learning from it. Maybe today, there's not a lot of druggable alterations that have a drug that is available to be given to pediatric patients. I think there's a lot of work still to be done, and unfortunately, we do not have a BRAF mutation or an NTRK fusion as other pediatric cancers with a drug that works beautifully and makes a big difference. But while the key aberrations include MICAN, ALK, RAS, ATRX, more and more we're having new trials open for targeting these aberrations. So it is definitely very useful to monitor disease, to identify new mutations, and to select the patients for early clinical trials. We might not be able to prescribe a lot of the drugs, but it is definitely making our lives easier when there are several trials or several arms in a trial, how to prioritize and how to select the patients. Still, not all neuroblastomas are profiled at relapse. They're not profiled in North America. They're not profiled in Europe and Australia or Japan, and that's a lot of work. Implementing the programs on the one hand, but also, as Gudrun was mentioning, on the technical difficulties. Sometimes these patients are not well enough to go to theater for a biopsy, or the biopsies are difficult to make, and some other times the technical difficulties still happen. So that's it is definitely a must that we need to do profiling for all patients with relapse disease. There are more and more data on actionable mutations, so it's an effort that we all need to do. And again, there's a couple of worthwhile abstracts in this conference. I wanted also to mention the first relapse trials that are ongoing. There's a couple of them in Europe: the REST trial, the Beacon trial, the 1221 trial, and the successors that will come. It is There's a NAN trial with MIBG with and without vincristine and irinotecan with vorinostat. It is very important to try to support recruitment to these trials, because it's the only way to have the next generation of data available. This is an example of the portfolio of options that we've got in COPEN ITCC, well, with the eSmart trial having a number of arms, with the INFORM 2 trial in Germany and other countries, the specific phase 1 trials with immunotherapy, with targeted agents, some consolidation strategies, and there's similar choices from NANT and from the COG phase 1 consortium. We are increasing the options for the patients with second or third relapses. But for phase 1 trials, still few relapsed patients are enrolled in early phase trials. We do not have a figure of how many neuroblastomas, how many relapsed neuroblastomas enter a phase 1 trial, but it is low. The number of patients that are recruited across the phase 1 trials is low compared to the relapses that we would expect, and that's a part of the differences between different centers, between countries. Not all countries and centers have the same options available. Another challenge is that small-sized and single-center studies that show promise need to be expanded to larger patient cohorts in the multi-center and international setting to show that the results are reproducible and maintained, and they can be taken forward. Regarding the large-sized phase 2 trials that I showed before, there's not a lot of trials that we can do at one time. So these pick-the-winner trials or multi-arm trials might have a role with all the time that it takes to set up clinical trials. Patient advocates and parent groups do mention it very often, that we do need to help the families accessing the early clinical trials, and that's something where we are not as fast as we could be, we're not as good as we could be, making sure that every patient with a relapsed neuroblastoma has the option of participating into an early phase clinical trial, if they wish to, of course. But we do need to make sure that across the whole Europe, the whole America, etc., we facilitate options for the patients that relapse. So that's part of the effort for the future. And then I only have one slide for the consolidation and maintenance. There are many options, and most of them have an abstract in this conference, so we will be updated on the bivalent ganglioside vaccine that is being developed in Memorial Sloan Kettering, about the humanized 3F8 monoclonal antibody, about the clinical trials with lenalidomide, with celecoxib, and DFMO, with haploidentical transplant. There's more and more options available for these patients. This is a concluding slide that I borrowed from Andy Pearson. We're not fast. I think that's the conclusion. We're not fast enough. We can say that there are a lot of advances, that a lot of things are happening, but we're not fast enough. We should concentrate on biology-driven drug development, on the mechanism of action drug development, on developing combinations of targeted agents with immunotherapy, facilitating access to drugs and international collaboration, more coordination and better trial designs. And I think that's a bit of a repetition, so I'm very grateful for the invitation, and we'll take any questions.